All right, let's move on then to brain injuries. And here we'll talk about the common pathological issues that we encounter in critical care nursing in the neurologic and neurosurgical populations. So to classify these traumatic brain injuries, let's start with this list. So it includes concussion, which everyone is quite familiar with, contusion, which is a little more involved, essentially bruising of the brain. Diffuse axonal injury is usually a blunt injury to the white matter tracts, and essentially this can be a minor or major problem. I've actually only ever seen it be a severe injury, but apparently there are milder forms of this. Whenever I've seen it, and most commonly we encounter it in high-speed accidents, where there's such a shear force applied to these white matter tracts that they no longer work. And so this is a devastating neurological injury that typically does not recover. Otherwise, we can have penetrating injuries for sure, and then hematomas where there's frank blood in the parenchyma. So those are primary injuries, but another major concern is secondary injury. So when you have traumatic brain injury, let's say you have a contusion of the brain, that by itself is a bad insult to the neurologic system, but it can be worsened if it doesn't get the proper attention for the primary problem, because the secondary consequence could be the edema and increased intracranial pressure and other things that complicate the original injury. So let's start with the hematomas that we commonly see. There are two major ones, right? There's the epidural hematoma and the subdural hematoma. And it has to do with the part of the brain coverings that are involved. And along the outsides here, you can see the common presentation and the a little bit more description about the pathophysiology. So an epidural hematoma is often associated with a fracture in the skull. There is a tearing of the meningeal artery that causes this blood buildup to form right between the dura and the skull. This is a medical emergency. It has to be evacuated and the bleeding controlled urgently. This classic presentation includes a brief loss of consciousness, then what we call a period of lucidity. That is where you or the patient has full awareness of what's going on around them and can participate and communicate, and then they have abrupt neurodeterioration. So that's the classic presentation with an epidural hematoma. The subdural hematoma is a collection of blood in the subdural space. This is a venous tear, not an arterial bleed. And because of the fact that it's venous, it tends to be slower. It can be acute, but often is subacute or even chronic. As I remember from when I was substantially younger, President Reagan was out riding his horse one day in the at his California ranch, and he fell off of the horse and hit his head, and nobody thought much of it. And months later, he ended up having brain surgery to get rid of the subdural hematoma that had happened months before. And that's a pretty typical presentation. So interventions for epidural, immediate surgery, including craniotomy. Recently on the Neuro ICU at Hershey, we saw somebody who actually had this complication, and they had to actually do the craniotomy at the bedside. Before, I had never seen that before, but the pressure in the brain or in the skull was increasing so rapidly that the patient would have been anoxic for a period of time had he not had the bedside craniotomy. That's pretty unusual, but that gives you some illustration of how serious epidural hematomas are. Again, remember they're arterial bleeds. And then subdural hematomas are often medical management, followed by the need sometimes for surgical decompression, even just burrs or a small craniotomy for hematoma removal can be done. We also have to make sure that we reverse anticoagulation if a patient has to go to the operating room for this. Burr holes are easily done at the bedside. They, essentially use a drill and use this burr hole right at the site that they want to decompress. Make an incision in the scalp, get down to the bone, drill the burr hole into the bone and right down to the dura, evacuate the hematoma, that is. Craniotomy is more involved, obviously, and essentially what they're doing here is taking out a piece of the skull. So what you can see on the left side of this slide is the patient who underwent craniotomy at some point. The skull piece is removed, and at the bottom center you can see that piece of skull that was removed, along with the hardware that they will use to reattach it to the skull when the wound can be closed. So oftentimes we'll see these patients in the ICU. Whenever they're out of bed, they need to have a helmet on because all of that area is exposed to brain and actually to the dura. But still, the potential exists for them to have a serious injury if they fall or hit their head. So post-op neurosurgery care includes hemodynamic monitoring, particularly monitoring of the intracranial pressure, of course, airway, breathing, keep the neck neutral. We do neurologic assessments every 15 to 30 minutes, up to 12 hours after surgery, and then every hour while they're in the ICU. Remember, these patients can turn pretty quickly, so you have to be on your toes. We have to recognize and prevent complications early. Those include increased ICP, intracranial hemorrhage, that's ICH. Seizures are a big issue. Anytime that you introduce blood or pressure or tumor or anything into the brain area, you can certainly have seizures. So many of these patients, almost universally, these patients are on anti-seizure medicines. Complications, there are many. These are all the things that we look out for as nurses, and we have to intervene quickly if that happens. Of course, we're also trying to do things to prevent these issues as much as can be, as much as we can. Next, we'll talk about aneurysms and arteriovenous malformations, or AVMs. Aneurysms, remember, are a weakening of the arterial wall due to the muscular problem in the media of the artery. About 10 to 30% of these patients die instantly before they reach the hospital. About 50% more die within a month, and the overall mortality of intracerebral aneurysms can be as high as 65%. So, of course, prevention is key for these patients. Patients who have a family history certainly are at higher risk for congenital malformation, and that should be evaluated prior to there being an emergency, obviously. There's also degenerative etiologies for this in patients who have connective tissue diseases like Marfan syndrome or lupus. And then there's also acquired, for which cigarette smoking is the biggest risk, but also hypertension, history of sepsis, and traumatic brain injury as well. Now, we talked about the circulation of the brain. Notice that aneurysms tend to form here where there's a bifurcation or trifurcation of vessels. And so these are the common sites that we see them. Many sites, about 25% in fact, are actually in the middle cerebral artery. But there are also some in the posterior inferior cerebellar artery, here at the posterior cerebral artery, right after the basilar artery. And then there's some, about a third, that occur in the anterior communicating artery, which connects the anterior cerebral arteries in the front of the brain. Clinical manifestations are that these patients are completely asymptomatic until something happens. And when something happens, they get the worst headache of their life. Their neurologic situation goes down quickly. They become lethargic. There's nausea and vomiting, terrible neck pain due to the meningeal irritation. They hear this noise in their head that they can't explain. And these are kind of the typical manifestations, but often it's sudden death. The diagnosis is made with a careful history, and some physical examination findings can help. A CT scan is helpful because CT scans show blood right away. Lumbar puncture will also reveal blood in the CSF, which is also a big help in making the diagnosis. And then we need to visualize it, and the way we visualize it is either with a CTA or an MRA in some cases, but often just direct digital subtraction angiography or an angiogram, where we inject dye directly and see the aneurysm here. And so on this image here, you can see this aneurysm in all of its glory, whatever the opposite of glory is. So the management required for treating these lesions is usually aimed at preventing rebleeding. And so we have aneurysm precautions that we practice. And that's importantly a bowel regimen, keeping the patient in a quiet environment, limiting visitors, etc. We use antihypertensive medicines. We have to prevent hyponatremia. In fact, we want to use hypernatremia oftentimes so that we can pull out some of the extra interstitial fluid that's becoming edematous there. Again, all aimed at trying to reduce the intracranial pressures. Stool softeners, pain management, etc. The way we intervene is very often by putting a coil inside the aneurysm, or in this case, you can see that the aneurysm was actually clipped. So this linear opacification here, another way to say that would be this line, is actually a clip where they clipped off the aneurysm that showed up over on the left side. Vasospasm frequently happens, and we have to control for this after the subarachnoid hemorrhage happens. It peaks within 3 to 12 days. Peaks within 7 to 10 days, but can occur anywhere in that range up from 3 to 12 days. It does cause cerebral ischemia, which is a major complication. So we have to try and limit that. So to do that, we use induced hypertension. That might not make a lot of sense to you until you think about the autoregulation that occurs in the brain, right? So if we make the patient hypertensive, then the brain is going to respond by vasodilating so that it can get enough blood to the brain parenchyma. We also use hypervolemia and hemodilution, and we use medicines like nimodipine or Nimatop, which is a dihydropyridine calcium channel blocker that helps relieve spasm in cerebral arteries. Other complications include hydrocephalus. There could be some reason that there's no drainage of the CSF happening. Seizures, again, anytime that you have blood or some other foreign substance in the brain parenchyma, that can cause seizures. There's certainly an opportunity for rebleeding. Hyponatremia happens, and that's a long explanation about how brain problems can cause hyponatremia, but it has to do with ADH and all that other stuff. And then cerebral edema as well. So that is the arterial malformations that we call aneurysms. There's another kind of malformation called an AVM, or an arteriovenous malformation. Now, forgive me for putting this picture in. This is a picture of an AVM. This is not a brain AVM. It just happens to be on the patient's forehead. So this is a cutaneous AVM, but this is the idea. When you have an AVM, the arteries and veins kind of get all mixed together. They don't have a good capillary network. Instead, the arteries and the veins communicate directly with one another. Now, if you know anything about veins, you know that they're not accustomed to carrying high pressure blood, and so you can have leaking in that AVM, and that can cause a neurologic event. So here's an AVM inside the brain that is being demonstrated here, and that AVM needs to get fixed somehow. So the way they do that is, well, we'll talk about it in a minute. The pathophysiology, again, is that the arteries and the veins essentially connect directly to each other because the capillary system fails to develop. That causes a huge amount of blood flow to go from the arterial system directly into the venous system, and that can cause venous dilation, and eventually that vein can burst open. So the way we see this clinically is in somewhere between 40 and 70% of patients, they have an intracerebral hemorrhage. Many patients may present with seizures because it could be an insidious bleed, but that blood by itself increases the seizure threshold, right? Or makes a seizure more likely, I should say. And then there's other signs like headache, increased intracranial pressure signs like change in level of consciousness, etc. But those are really in the minority. Most patients present with an acute hemorrhage or a seizure due to insidious blood leak. We make the diagnosis in the usual way with CT, MRI, angiogram, magnetic resonance angiography. TCD is transcranial Doppler, so an ultrasound of the head to look at blood flow through those vessels. We can use SPECT and PET scans. I've never seen that used, but I guess theoretically it could be. And then functional MRI as well. Again, haven't seen that used. This is that technique where you see patients go into an MRI machine and then they show them pictures of things, and when the pictures make them happy, then it lights up a certain part of their brain. When the picture makes them sad, it lights up a different part. That's functional MRI. There's a lot of question about how useful that technology is, both in research and in clinical medicine, but apparently it's used from time to time. So the management of these lesions often involves endovascular embolization. So you get in there with the catheter-based approaches, find the AVM, and just start closing off areas of flow. Now you can imagine that when you do that, you don't really know what's supplying tissue and what's supplying the AVM. So it's a little challenging to do that. The other thing that can be done is this gamma knife surgery, which is actually radiation that's focused very tightly, and that radiation is used essentially as a knife. That's why they call it a gamma knife. And they can actually use that to deliver very, very specific energy to a very small locale. And then, of course, there's surgery too. But, these AVMs are really a difficult thing to deal with because, you don't want to make healthy brain tissue ischemic, but at the same time, you don't want to leave the AVM open so that it can rupture. So these are some of the neurosurgical approaches that can be used. Craniotomy, I think, is a fairly well tried and true method, depending on the location, right? Whenever you get into the deep regions of the brain, then sometimes catheter-based approaches are superior. All right, let's talk about cerebrovascular accident. Here you can see a patient with a right facial droop. We're going to talk more about that as well. So stroke is a neurologic deficit that we used to call stroke and cerebrovascular accident and all that stuff. But over the last, 10 years or more, we've been referring to it as a brain attack. So, a heart attack is acute ischemia of the heart, and a CVA is acute ischemia of the brain. And so it makes sense that when if we want to get patients and families and the public to react acutely and know that time is brain, if we call it a brain attack, that might help. So that's what we've been doing for 10 years. We call it a brain attack so that we can attract attention to the urgency of this. Stroke, patients and families and the public tend to associate with, oh, he had a stroke, that's too bad. But if you say brain attack, then hopefully patients' families will say, oh my God, he's having a brain attack. We have to get him to the emergency room right away. And that's the idea behind a brain attack. There are two kinds of strokes. There's ischemic strokes, where there's a lack of blood flow to a particular area. And then there's hemorrhagic strokes, where there's actual bleeding into the brain. And it's important to differentiate which is which. So strokes, about 80% of them are ischemic in nature. Some of them may become hemorrhagic, as they evolve, but ischemic strokes happen due to emboli from the heart, in atrial fibrillation, for instance, or in patients who have severe decreased LV function. If they've had an anterior MI and they have apical hypokinesis, very often they will form LV apical clot, and that clot can go to the brain. But by and large, what we see is embolic strokes from atrial fibrillation. Thrombotic strokes, where a thrombus forms in a vessel, happens more frequently, about 75% of the time. And when we see it, we usually see it in the middle cerebral artery distribution, but we also see it in these other distributions as well. So just bear that in mind. Hemorrhagic stroke tends to be intracerebral oftentimes, but the subarachnoid hemorrhage can happen about a third of the time. The pathophysiology is this. There are different levels of stroke. First, we have, so picture, and I should have put an illustration of this in there, but picture the area around the stroke in the brain having zero blood flow. That is an area of infarction. But around that area of infarction is limited blood flow, and that is the zone of ischemia. And the zone of ischemia we want to limit. And the way we limit that is by getting to these patients early and intervening right away. Whenever there's damage to the brain from a stroke, there's always cerebral edema. And in fact, when we look at a CT scan from a embolic or thrombotic stroke, anything but a hemorrhagic stroke, if we look at the CT scan 24 hours later, we don't actually see the stroke. We see the effects of the stroke, and the effects being cerebral edema. It's not for much later that we see the actual stroke evolving, but rather early on we see the effects of the stroke shown as cerebral edema. So you might be wondering, why do we do a CT scan at all? Well, we do that when the patient comes into the emergency room because we're interested in knowing how to treat this patient. If we see any bleeding, then we know that we can't give thrombolytic therapy, and we have some limitation in our therapies. If we don't see bleeding, then that opens us up to consider things like thrombolysis. Anytime that we have a stroke and increased intracranial pressures, we have the potential for herniation. So we always have to keep that in mind as well. So a couple of things for you to know. First of all, when you have a left hemispheric CVA, which by the way would cause right-sided symptoms, right? When you have a left hemispheric CVA, these are the ones that potentially have language issues. So we have Broca's area that lives in the left hemisphere, and we have Wernicke's area. Broca's area is associated with expression, right? And Wernicke's area is associated with reception, so receiving language signals, understanding the words that are being spoken to the patient, that kind of thing. But Broca's area is responsible for getting the words out through speech. And so depending on what part of the brain is affected, you may have either expressive aphasia if it involves Broca's area, or receptive aphasia if it involves Wernicke's area. I'm sorry, I'm pointing to the wrong thing. Wernicke's area is this little thing here. Okay. Other manifestations: weakness, numbness that localizes to one distribution. You may have those upper motor neuron findings that we talked about. Remember what they are? Babinski sign, upgoing toe on the contralateral side. Hyperreflexia on the contralateral side, and I should say clonus on the contralateral side. Dysarthria, which is the inability to speak clearly. Dysphagia, which is the inability to swallow correctly. And then aphasia, as I said, either expressive or receptive. So expressive aphasia is I guess I can illustrate it best by speaking like this. I had like that. The patient has word finding difficulty. It's very hard for them, very frustrating. They can't get out what they want to. They know exactly what they want to say. They have no idea how to say it. Receptive aphasia is a little harder to diagnose. Well, it's a lot harder to diagnose, and it's actually a very involved testing that speech-language pathologists and others can do, but it's a little beyond what I understand because it's so involved. The language center in the brain is so complex. And language itself is so complex. It's not just the ability to speak, but also the ability to interpret, the ability to read and understand language and cues and things like that. So with receptive aphasia, patients are often very fluent in their speech, but what they say makes no sense. So they may hear you ask a question, they look at you like you have 10 heads, and you just don't break through to them at all. But if you write that sentence down that you said to them, they might understand it. All right. Again, not always. It's very complex when this happens and when it doesn't. And it takes somebody who really understands this phenomenon to be able to get to the bottom of it. But as I said, they may be very fluent in what they say. It just might not make any sense. So they may say a sentence like, my brother came in the socks with his chili in the foot powder. Right? Which makes absolutely no sense. And they'll say it as if they have just spoken the gospel truth, and they will have no compunction that what they had, that what they have said is gibberish. And they'll look at you expecting you to give your response to their statement. And so it's a very fascinating thing. Now, on the right-hand side here, I have a couple of things for you to look at. And this is one of the really cool things that I like about neuro. You can actually localize the area of a stroke based on a few little clues from the physical exam. Neurologists are always the best diagnosticians, and so they can really localize at an even deeper level where these things happen. So let me just walk you through this a little bit. If somebody has an optic nerve problem, right? Or if their eye falls out, then they will have monocular vision as shown here in number 1. So if they have a problem that's primarily with the optic nerve, the signal won't get back here and they will not be able to see out of that eye at all. If they have a lesion at the optic chiasm, then they get tunnel vision essentially, where the outsides of their visual field are impaired. And so tunnel vision goes along with a lesion right below the optic chiasm, and guess what lies right beneath the optic chiasm? Right below the optic chiasm is the sella turcica, and inside the sella turcica lives the pituitary gland. So the pituitary adenoma often produces this tunnel vision that can be assessed with good technique. And when you see that almost always, when you see this visual field deficit, that almost always means that there's a problem, that the problem is due to a pituitary tumor. Now, look at this. This is homonymous hemianopia, right? Number 3. And this has to do with lesion in the optic tract. And what's in the optic tract but let me put it this way. The optic tract is generally supplied by the middle cerebral artery. And so when we have a stroke in the MCA distribution, which is all this area right here, right? You see this area right here. This is MCA distribution. And we may have this homonymous hemianopsia. And when you have this feature, we have unilateral neglect, right? So the patient doesn't even know that anything exists other than on the left side of their tray, right? So these are the patients who only eat half of the food that's on their tray. It's only on the left side. All the stuff on the right-hand side will remain untouched. It won't even be seen. And these patients need special reminders all the time to scan the tray to look for other things. That same visual field deficit minus the central vision cut happens when there's an occipital lesion. And I have seen this a time or two where they have preserved central vision, but they have what otherwise would be hemianopia. And then there's homonymous quadranopia. Again, if it's the upper quadrants that are involved, that speaks to a different area of the brain than if the lower quadrants are involved. So I just think this is fascinating that you can do a really good exam using that, covering your eye, covering the patient's eye, and wiggling your fingers in between you. If you're interested in that, I would love to help you learn to get that technique down, because this is a really fascinating thing, and you can be a hero when you discover this visual field deficit. So how do we make the diagnosis? Well, we have to make sure that we get to these patients right away so that we can consider TPA. And there's a whole checklist that we have to use in order to figure out if patients qualify for TPA. And part of that checklist is using the NIH stroke scale, which is shown to the right here. Those of you who have done the NIH stroke scale in clinical or in the sim lab know that it is a very complex tool. It requires special training in order to administer it correctly, but it is very useful in gauging the severity of a stroke. We also use differential diagnosis. That is to figure out what else could be causing these same symptoms. Is it a stroke? Is it a tumor? Is it head injury? Is it psychiatric in nature? What is the nature of the symptoms that the patient is presenting with? A CT scan urgently, of course, will not show the stroke, but instead it shows if there's any bleeding. And that's important because we want to not give thrombolytics if there's bleeding. And then we do other diagnostic testing like MRI or angiography or such. The clinical management of ischemic stroke is either watch and wait, which is, one way to proceed. It's not always the wrong way, because the downside of giving TPA and having an intracerebral hemorrhage is so abhorrent that oftentimes we're content to just wait and see, how the patient does. If it's a relatively small area that we're not, the patient should be able to recover from without a whole lot of trouble, sometimes watchful waiting is okay. But it's hard not to be aggressive in young people, right? And in that case, we oftentimes want to give TPA and just hope and pray that they don't have any hemorrhagic conversion. I remember a patient that we had in the neuro ICU a couple of years ago who was just furious. She came into the hospital the day before after having a stroke. She got TPA. The TPA didn't work very well, so they took her to the interventional laboratory, and they used a clot retrieval device like pictured here, and they pulled out the clot, and she had complete resolution of her symptoms. The next day she was furious. She's like, I'm fine. Just let me go home. Everything's cool. Well, yeah, everything's cool because we did miraculous things and got this clot out of your brain, and you have no idea how close you were to not having a quality of life anymore. And, just calm down and take a little break. You're lucky to be here, and let's not be in such a hurry to get out. I'll just never forget that. The point of that story is not anything about the patient. I don't expect her to understand the gravity of the situation right offhand. But the reason I tell you this story is because of how miraculous some of this stuff is now. We give the thrombolytic agent. If it doesn't work, then we take him to the interventional lab. We can actually pull out the clot. Like, how awesome is that? Pull out the clot, restore normal blood flow to the brain, and have the patient angry the next day that they can't go home because they feel so perfect. I mean, it's just amazing. It's a great time to have a stroke. I mean, don't have a stroke, but look, if you got to have a stroke in history, now's the time to do it, right? Because we have some things that we can do. Now, one of the other things that leads to strokes is carotid artery disease. And so there are two ways that we can deal with carotid disease. One of them is the old-fashioned carotid endarterectomy. In the best of hands, this surgery has about a 3% complication and stroke rate. What they do is they open up the vessel, they find the plaque here, and they open up the vessel, pull out the cholesterol stuff, sew everything back up. Patient goes home, and then they don't have a stroke. That's beautiful. We love that idea. It's kind of a big deal, though, right? Have somebody operate on your neck. There's a substantial chance of bleeding into that area. And of course, if you bleed into your neck, you can have a big problem in a hurry. A hematoma in the neck can cause pressure to be exerted on the vessels, breathing, and all sorts of other things. And you can be in extremis very quickly. So because it's kind of a big operation, people have gotten the idea that maybe there's some other way that we could proceed. Well, there is. In fact, we now stent these vessels with just about the same sequela or side effects of the endarterectomy. And the first thing that happens is we put a catheter in through the groin, and we put it past the plaque and inflate this device distal to the plaque that is essentially a net, and that net catches any debris that pops off while we're doing this procedure. And then we put a balloon in here, and around the balloon is a stent, and we open up that vessel and smush the plaque up against the wall, and then we pull out the balloon and catheter and leave the stent in place. Any of the trash that falls off during that procedure is caught in this little net, and then we pull the net out, and everybody lives happily ever after. Not a zero chance of a problem, of a complication, but pretty low. And, as I said, in the very best of hands with the carotid endarterectomy, the operation, we have about a 3% stroke rate. And the stenting has about that same 3% stroke rate. Now let's talk about hemorrhagic stroke. So that was all ischemic strokes. Now we're going to talk about hemorrhagic stroke. We make this diagnosis by CT scan, right? We can see bleeding into the brain with very little with very little time between the onset of symptoms and when they get to the emergency room. That blood is visible immediately, even though with an ischemic stroke, we don't see the effects of that stroke for a couple of days. We can see blood on the CAT scan right away. So everybody gets a CAT scan when we're concerned about a stroke. And then if they end up having a hemorrhagic stroke, then our management changes. Then we are concerned with aggressive blood pressure control and managing the intracranial pressure, and unfortunately kind of hoping for the best. Seizures are a major problem when there's bleeding into the brain, as we've talked about before. And so we have to make sure that we are treating that. And we're going to talk more at the end of this lecture about how we treat that. In fact, we're going to talk about it right now. So the etiology of seizures is there are multiple etiologies. As I mentioned earlier, we see it in neurosurgery populations frequently because the brain cannot take a joke, right? So anytime we cut into the brain or bleed into the brain or have a tumor in there, any of those things increase your likelihood of having a seizure. So much so that when we see a tumor, for instance, we usually just put you on anti-seizure medicines right away. There are seizures that are idiopathic. We have no idea why people have those seizures. Some seizures are caused by vascular disease. Some seizures are caused by alcohol. Actually, it's not the alcohol that causes the seizure, but rather the withdrawal of the alcohol that causes the seizure. Think about it. What's alcohol do? It's a CNS depressant, right? So we depress the brain and make it less likely to have a seizure while it's getting the medicine or while it's getting the alcohol, or when patients are in the hospital and they're at risk for withdrawal, then we give them a benzo, which is also a CNS depressant, so that they're less likely to have a seizure, right? So remember, with the alcohol, it's not the alcohol that makes them have a seizure, it's the withdrawal of the alcohol. So we have to do that in a carefully controlled environment. All right, and you can read the other etiologies here. We've talked about most of them as well. So what are the variables that mess with the seizure threshold? Fatigue and sleep deprivation are not the first things that you think of, but they are very common in potentiating seizures. Emotional and physical stress. Menstruation can do it. I've seen menstruation cause all sorts of cardiovascular problems, SVTs, and sudden cardiac death. I've seen that a couple of times. It can also be associated with seizures. Pregnancy. It's funny, when you have these problems before you're pregnant, it seems that when you're pregnant, they all go away. Or if you didn't have any of these problems before you were pregnant, then you get pregnant, now you have problems. It's weird. I don't understand that. Menopause can also be a contributor. Alcohol and drug abuse, as we talked about. And fever. We all know about kids having febrile seizures. Well, it can happen in adults too, although it's not benign when it happens in adults. So we have different classifications for seizures. We have the two main classifications as partial and generalized. So generalized seizures tend to be that grand mal kind, or you can have absent seizures, which are like petit mal or staring. They just get these staring fits where they can't focus on anything else. And then drop attacks, where you just have a syncopal event, you lose consciousness. You don't necessarily have the tonic-clonic grand mal or convulsion, but still can be a generalized seizure. And then myoclonic, where you have these sudden muscle jerks that are uncontrollable as well. And contrast that with partial seizures shown here in purple, which include simple partial seizures where you actually know what's going on around you, or complex seizures where there is an altered awareness, and you may behave rather strangely too with tics and things like that. So these are the general seizure classifications, and we sort of go back and forth. When I was in school, we said there was no such thing as a grand mal seizure. We didn't use that term anymore, but it never really disappeared. We use that term all the time now. So how do we treat these things? Well, there's the old and the new. And oftentimes the old is, the staid and true, and the new stuff never really pans out. Well, that's not the case with seizure control. In the old days, we used this horrible drug called Dilantin. And Dilantin was the only anti-seizure drug that we had that worked. But it was a mess to use. It messed with the sodium channels, and it made some patients toxic and caused things like this gingival hyperplasia that you see on the right-hand side here. Can also give people a skin rash called Stevens-Johnson syndrome. It can mess with other drugs like warfarin and oral birth control pills. I mean, it's just a complete mess. Not the least of which is the fact that it has a very narrow therapeutic window, which means that we have a very, very thin line that we walk between not getting enough to prevent the seizure and getting too much, which makes you sick. So it is not a cuddly drug, all right? Dilantin is not one of those cuddly drugs that we love to give. The other reason that we don't like to give it is because when we give it IV, things like this happen. So this is an extravasation injury from Dilantin that was administered to this poor kid. We can also see problems with cardiovascular collapse if the Dilantin goes in too fast. And of course, it's incompatible with everything, including, like water. I mean, it's just a pain in the neck to give. Now, there is a prodrug called Phenytoin. Instead of Phenytoin, it's Phenytoin. That's a prodrug, which means that it's administered as Phenytoin, gets into the body converts it to Phenytoin, which is the active component. Less cardiovascular risk, less chance for extravasation injuries, things like this, but still not a cuddly drug. So more recently, we've had less problematic drugs, but none of these are cuddly either. So Tegretol, Depakote, these medicines also have narrow therapeutic windows and potentially dangerous side effects, not the least of which is bone marrow suppression and liver poisoning. And we still have the Stevens-Johnson syndrome to deal with. And so we have to get levels on all these patients. Not a cuddly drug choice either. So what has really revolutionized the world of seizure disorders is Keppra. Keppra is everybody's favorite drug now. Of course, it has my favorite mechanism of action, right? Exact mechanism of action unknown. I love that. Like, we give the drug, we have no idea how the hell it works. What we do know is that it decreases the incidence of seizures. It has no significant interactions. It has a wide therapeutic window, so we don't have to monitor levels. It does have a little bit of a sedative effect, but with this side effect profile, who cares? I mean, we're so happy to have this drug, and it's available in solution for injection or in oral form. This is a medicine that you're going to see used probably as a first-line agent for anybody who has a seizure disorder, and it's a really wonderful thing. Still, there may be patients who don't respond. And in that case, there are some surgical approaches that can be used. One is a vagus nerve stimulator. So this vagal stimulator actually gets wrapped around the vagus nerve, and the generator down here somehow works. I have no idea how it works. I just think it's magic. But it causes stimulation of the vagus nerve, which somehow produces less chance of seizure. Again, I think it's just magic. I don't really know how it works, but it's very cool. There's some other things that can be done, like that are pretty dramatic for patients who have status epilepticus, a temporal lobectomy, where they actually take out the temporal lobe. Sounds pretty dramatic, but you know what? If you have intractable seizures, that might just be the thing that you need. In young kids, they can do a hemispherectomy, where I think before the age of 6 or so, they can take out the entire hemisphere if it's jacked up. So you take out half of the brain. If you do that to an adult, the patient dies. And if they didn't die, they would have absolutely no use of the other side of their body, right? But in kids, their brain can actually learn to do the work of the other side of the brain that has been removed. And there's one guy who used to practice at Johns Hopkins back in the 80s. He sort of revitalized this procedure, and his name was Ben Carson. And you may now know him as the Secretary of Housing and Urban Development. Kind of a weird path that he led from being one of the most brilliant, innovative neurosurgeons in the world, who, separated conjoined twins and did just incredible kinds of work, to now ordering expensive office furniture and managing HUD. It's a very strange picture, but be that as it may, he was one of the great pioneers to bring back that procedure in kids. And so those are some of the other management options for epilepsy. I know it's been a long week. There's a lot of content here. Neuro was overwhelming, but you made it. We're all done. Now there'll be some learning activities for you online, and I hope you have a good week.